Hello everyone. Today let's learn about acute renal failure. So what is acute renal failure? Acute renal failure is any injury that's caused to the kidney which leads to the failure in the function of the kidney. So what is the function of the kidney? It is mainly removal of your nitrogenous and other wastes from your body. So broadly the causes of this acute renal failure can be divided into pre-renal, intrarenal and postrenal. So let's look at each of these individually. Now first, coming to the pre-renal cause, what exactly is the etiology of the pre-renal cause of acute kidney failure? So this is mainly due to hypovolemia, which can be caused due to a decreased cardiac output from the heart or due to heart failure. So if this is the kidney, its main blood supply is from the renal artery. So if there is hypovolemia, there is less blood reaching the renal artery, and hence there is less renal blood flow to the glomerulus, which leads to a decrease in GFR. So this forms the pathophysiology of this pre-renal form of acute kidney failure. So due to a decreased renal blood flow, it leads to a decrease in GFR, which is the main cause of your clinical features and symptoms that the patient presents to you with. So let's see what are the clinical features. So the patient comes to you with oliguria. This is because you have a decreased GFR and hence this decreased filtrate reaching the tubules, which leads to less urine formation. So the patient presents to you with oliguria. And there is also azotemia. What is azotemia? Azotemia is accumulation of the nitrogenous wastes in your blood, and this is due to failure of the kidney function, which is mainly removal of nitrogenous wastes. So you get azotemia when you have an acute kidney failure. Now coming to the investigations, there are a few investigations which are very important and which will tell you the cause of acute renal injury or acute renal failure. So the first one is you check the urine osmolarity. So this is going to be more than 500 milliosmol per kg, which means that the urine is very well concentrated. And this tells you that the tubules are functioning properly. Tubules are functioning properly. This is because the main function of concentration of the urine is the tubules. Is from the tubules. So this means that the tubules are functioning properly. So your cause of acute renal failure will be something else, which can be hypovolemia, that is a pre-renal cause. Now you check for the urine sodium. Urine sodium will be less than 20 milliequivalent per liter. So this tells you that sodium is very well being reabsorbed into the body, which is again a function of the tubules, which again tells you that the tubules are working properly. Now FeNA is basically fractional excretion rate of sodium, which will be less than 1%. So this again tells you that the tubules are working properly, and this can lead you to the conclusion that the cause can be hypovolemia or decreased blood flow to the kidney. Now this last one is a little important, that is you check the serum BUN is to creatinine ratio. These are the nitrogenous products present in your body. So the normal BUN is to creatinine ratio is equal to 15 in your body or in your blood. But in this case, it's more than 20. So the reason is that, assume this is your tubule and the filter load through the glomerular filtrate comes in, which contains BUN as well as creatinine. Okay, so this goes out for excretion. But what happens is that creatinine is freely excreted, whereas some part of your BUN is reabsorbed. Now, in this case, when you have hypovolemia, what happens is that there are other mechanisms which are stimulated, that is, there's stimulation of RAAS system because there's decreased cardiac output, and this leads to release of aldosterone. Now, what does aldosterone do? Aldosterone leads to increased reabsorption of sodium and water, right, from the tubules. So along with this water, there is excess of BUN also reabsorbed in this case. So exclusively in this case, there's excessive BUN reabsorbed into your blood or the body, so your serum BUN is increased when compared to normal. So in this case, the ratio becomes more than 20. Now next, coming to intrarenal causes. We have just seen the pre-renal cause. Now let's come to the intrarenal cause. What is the etiology of intrarenal cause? It's anything that leads to any pathology in your kidney, within your kidney. So it can be tubular and interstitial, that is, it can be your acute tubular necrosis, and this can be due to ischemia, that is reduced blood supply. So this is also it can be preceded by a pre-renal cause. So long-standing reduced blood supply can lead to ischemia, which can lead to acute tubular necrosis, or it can be any sepsis, infection, or nephrotoxic drugs. And another one in this is acute interstitial nephritis. That is, your interstitium of the kidney undergoes inflammation and there's a pathology there. Now it can also be a pathology in the glomerulus, that is acute glomerulonephritis. Or it can be a vascular one, that is vasculitis, malignant hypertension, or TTP and HUS, that is thrombocytopenic thrombocytic purpura or hemolytic uremic syndrome. And this can also lead to a primary pathology inside your kidney. Now coming to the pathophysiology of the intrarenal cause, what happens here is that mainly, so now for example you have a acute tubular nephritis, you have the epithelial cells of the tubule undergoing necrosis. So due to this necrosis, first thing is there's a loss of function of the epithelial cells, and second thing, this necrosis and the debris of the necrosis starts accumulating in the tubules. If this is the tubules and these are your epithelial cells, there's damage to this and necrosis, and this debris starts accumulating within the tubules. Now this causes obstruction of the tubules. So there is, when the GFR comes in, it cannot travel further, so there's an increased backwards pressure or backflow pressure at the glomerulus. Okay, so due to the backflow pressure, there will be a decrease in GFR. Now this decrease in GFR again leads to your symptoms and clinical features. So again, what are the clinical features? They will be oliguria and azotemia, because your main kidney function is not taking place and your GFR is also reduced. So again, you'll have oliguria and azotemia. Now coming to the investigations, they are slightly different from your pre-renal ones. Now your urine osmolality will be less than 350 milliosmol per kg, which means it is decreased. It means your urine is not getting concentrated properly. This is because your tubules are damaged. Your tubules are not working properly, and they are the ones that actually are supposed to concentrate your urine. So this can tell you that the cause can be some pathology within the kidney or an intrarenal cause. Now the same way, the urine sodium will be more than 40 milliequivalent per liter, which will tell you that the tubules are not reabsorbing sodium and water appropriately. Again, this will lead you to the conclusion that the cause can be an intrarenal one. Now, the fractional excretion rate of sodium will be more than 2%. That is, you will find more sodium in the urine, and this is again a feature of any tubular damage. Now, this one, your serum BUN is to creatinine ratio will be less than 15. That is because your tubule has lost the capacity to reabsorb BUN, and hence your serum BUN relatively decreases. So hence the ratio will be less than your normal ratio. Now moving on to these two important conditions which include your intrarenal cause, that is, first one is your acute tubular nephritis. So in acute tubular nephritis, as I already told you, due to the necrotic debris, you will find epithelial or granular casts inside your tubule. Now this can be caused by ischemia secondary to decrease in renal blood flow, as I told you, or it can also be due to nephrotoxic drugs like aminoglycosides which damage the tubules. Now the next one is acute interstitial nephritis. This is a damage to the interstitium of your kidney rather than your tubules. So again here the patients present with azotemia because the kidney function is not being taken properly, and also with pyuria because there's a infection and inflammation of your interstitium, so you will be seeing eosinophils on microscopy. Now this can be due to any drugs which cause a hypersensitivity reaction, and these drugs act like haptens, and they can be anything like diuretics or NSAIDs. So a patient with acute interstitial nephritis presents to you with fever, rash, this is supposed to be hematuria, then pyuria, and there will be costovertebral angle tenderness. So any patient that comes to you with the investigations of the intrarenal cause that we just discussed, and also with all these features, you can confirm the diagnosis as acute interstitial nephritis. Now coming to the postrenal cause, which is the last cause. Now what is the etiology? This can be anything that leads to obstruction. So assume this is your kidney and this is your ureter, which leads to outflow of urine. Now any obstruction outside the kidney, that is post urine outflow from the kidney, here this can lead to the postrenal cause of acute kidney failure. So it can be anything like stones, benign prostate hyperplasia, any neoplasms, or can also be any congenital anomalies. Now what is the pathophysiology of this? So again it's the same. There's obstruction of urine outflow, so there's a backflow pressure this way. This also leads to a backflow pressure towards the glomerulus, and this leads to decrease in GFR, which presents with symptoms and clinical features. Now here the clinical features and investigations are more or less similar to the pre-renal cause. So the patient presents to you with oliguria and azotemia as usual. Okay, and in investigations what you find, obviously the tubular function is normal, so your urine osmolality, then your urine sodium and your fractional excretion rate of sodium, all of it remains similar to pre-renal cause. And also the ratio of BUN is to creatinine in the serum is similar to pre-renal cause, which remains more than 20, but the cause is slightly different. So what happens here is that, let's assume this is the tubule, and you know that there's obstruction, so there's an increased backflow pressure. So your glomerular filtrate is here, BUN and creatinine. So due to obstruction and increased backflow pressure, what happens is that this leads to excessive reabsorption of BUN because your tubular function is normal. So the excessive backflow pressure, excessive or increased backflow pressure leads to excessive reabsorption of the BUN. This leads to an increase in ratio compared to the normal. Okay. Now this ends our discussion on acute renal failure. Thank you.